So much for inviting me. It's an absolute delight to be here, my first time in Ireland, and so far so good. So I'm going to be talking about work and workflow, but in particular with a bit of a focus, as you'll see, is going to come through. So, I'm having clicker issues already, I do apologise. So evidence-based practice is the gold standard. We all pride ourselves on hopefully being evidence-informed clinicians. We would perhaps see ourselves as hopefully research sensitive. We read the latest literature and we try to implement that to inform our clinical decision making. You know, the College of Podiatry is also affiliated to the Science Council. We have the opportunity to be chartered scientists. We're taking this quite seriously. And so I'm going to just ask you now, are you a scientist in the clinic? Is it enough to be just simply research informed, or can you be implementing research methodologies in the way that you actually act in clinic? So you may have a Bachelor of Science degree, but are you afraid to use it? So, does it matter? Come on, there we go. Does it matter? Well, of course it matters. As we've just said, evidence-based practice is the gold standard. And so rather than having this kind of situation over here, which is what you would perhaps have if you were attempting things in a very sort of habitual way, something where you might do the same test on every patient all of the time because you feel really comfortable doing that. Perhaps if you challenge yourself a little bit more to step out of your comfort zone, to read around the subject area and apply a systematic framework to the way that you practice in your assessments and your clinical decision making and your therapies, you might hopefully find yourself to be more over here, a little bit more direct in the way that you end up seeing the expected results that you were hoping for. So you will all be familiar with SOAP. You were all taught SOAP notes when you were training, the subjective, objective. You might see A for being analysis or action, depending on where you trained, and then planning as well. Some of you may also have heard of SOAPIA. And this is what I'm going to try and expand on a little bit today. It's what we're teaching now at Plymouth. It's actually implementing this scientific methodology right from the outset so that it becomes almost like the lyrics of a song. The first time you heard the song, you didn't know the words, but you got the tune. Then you learned the first chorus, and then you kept learning it until now, whenever it comes on the radio, you just sing along. It's that automatic. So I was saying to Martin, I'd like to talk about work and workflow because it should be that automatic, but without any detriment to quality along the way. So I'm going to introduce the remaining parts of the SOAPIA cycle here. So you might have come across, like I said, subjective, objective, analysis, and planning. They are still there, but now we add on implementation, evaluation, and review as well. So hopefully this will become something that you can play out almost every time that you encounter a patient. You have, of course, got to inform it, though. You've got to do your homework and your reading. There is no substitute for turning up informed. So we start off with the subjective. Now, we all know history is king. That's no news to anyone. It's really important that you approach that history taking in a targeted manner, though. Do not waste a second of this. This is the most important part of your assessment. So what you need to be doing is thinking about what you want out of it before you go into it. Remember, you put rubbish in, you get rubbish out. So it's up to us to form good habits to get good results. So what I would like you to start to think about is, for example, thinking about things that will be limitations to the results that you're hoping to get. It might be that you think you can achieve something, but you hadn't factored in maybe they're not quite up for the engagement in rehab that you'd hope that they might be. So you should be thinking about identifying flags. We've got the clinical flags here, red flags, orange flags. You'd be aware of those. You know, you don't carry on if someone's bleeding out in front of you. It's a red flag, it's a clinical emergency, call the ambulance. Orange flags are very similar. These are the psychiatric versions of the red flags. So any destructive behaviours, things that really mean they're just blocking from moving forward. The final colours that are just hiding behind here, though, are the ones that you really want to tune into, and tune into them early. They are make or break in terms of whether you get that success or failure with your patients. So the yellow flag, this is the one that we all perhaps know, and it's very easy to flag a patient by being negative in front of them. The yellow flag is about the patient's belief about their condition, and that can be absolutely critical to whether they buy into what you're then recommending that they do to manage their condition. So identifying yellow flags is really, really important. Similarly, the blue flag is about their beliefs about the context they're in, often work-related. So it might be that they think they haven't got a good relationship with their manager, and doing, I don't know, coming into your clinic 4 times a week or whatever might just put that job at risk, and they're scared of that, so then they might not engage with your therapy. So again, just being mindful of these beliefs is really important. Similarly, when we get down to the other end here, we've got the black flag, which are actual conditions. These are things like having to wear steel toe cap boots. Don't go negotiating too much on footwear. They have got to do what they've got to do. But then the one I've just missed out, and that's the cool one. This is the one that hasn't had much literature published about it yet, but it's the one that I buy into loads when I'm working with people. This is the motivating factors. These are the things that drive your patients. These are the things that, if you can hook into those, you're basically drilling into their psyche to get them better, because they want it as much as you want it. So that's the factors, the psychosocial stuff that is the art of podiatry. This is the way that we actually engage with our patients, our service users, and engage with them as human beings, people who are actually attached to that foot. But also don't forget that we've got to get down to the nitty-gritty as well. So when you're thinking about that medication they're taking, the symptom that they're complaining of, their primary complaint and so on, think about populating it through the lens of what we call SIN factors. This is the severity, irritability, and nature of the problem. Now, I take 4 pain scores. I take the pain score at best, the pain score at worst, the average pain score, and their pain right now. And the reason I do the pain right now is because in a minute I'm going to start doing some tests on them. And if they're really irritable and they peak up to a really high pain score, I'm going to throw up loads of false positives. So by populating the SIN factor, how irritable they are, does it come on really quickly? Will it be provoked if I do an ankle range of movement on them or something? And the nature of the problem, I can decide what I do next and hopefully do a really accurate objective assessment. So when you're clerking, think about all these things, because now you're going to be formulating your hypotheses. This is your shortlist that you're going to sieve out in a minute with some good tests. So you want to go into your objective assessment, knowing what you're looking for, and like a game of Guess Who, the ones with brown eyes, you flick down until you get the ones with only moustaches left, and then you really have got just to identify that one thing that is remaining, that one person remaining on the game. So the SIN factor is the other thing that you should be thinking about when you are conducting your subjective assessment. When you get into your objective assessment, you should be thinking about now, like I say, eliminating the things that it isn't and leaving hopefully the thing that it is, because that's going to be the thing that will hopefully become your diagnosis. So what I do when I come into an objective assessment is I want to get some good test results. I want real information, not just convenient information. I want the information that hopefully I will have maybe 3 good tests and they'll all agree. Because clinical tests aren't that sensitive and specific frequently. They're moderately reliable, moderately sensitive, and you don't always get the real result out of one test. So by doing 3 tests, you'll probably get nearer the truth. If you need more information, you could maybe go and order some investigations. But if you get 3 good tests that you're confident they're not getting false positives or false negatives with, you're probably getting nearer to the real condition that you're dealing with. So what we're basically doing here is we're applying something called the clinical principles of the clinical prediction rules. You might have just read them in one of the podiatry blogs that comes out regularly. But physiotherapy have been using this for years. The Ottawa ankle rules that we all use to decide on whether we take an ankle x-ray or not, that's an example of diagnostic clinical prediction rules. Now they're quite mathematical, we're not going to go into those right now. But what the principles of it are is that if you can get agreement in 3 good tests, the chances are it's looking like a duck, quacking like a duck, flapping its wings like a duck, it's a duck. So you can start treating it as that thing. But if it's wagging its tail like a duck but barking like a dog, then you probably need to get more information. So this part of the assessment is about drilling down. You're really getting down to the nitty-gritty, and you're beginning to hopefully get to the crux of the problem. So, oh gosh, there we go. I don't know why it's doing that, sorry Martin. Right, we got there in the end. So now we arrive at the analysis stage. Now, as I said, you may have a degree, but don't be afraid to use it. This is the stage of the assessment where, this is all quite laboured talking about it right now, but actually this is the point at which you can really begin to take the time out, use your space, use your clinical diagnostic tools in your head, and start to determine what the actual diagnosis is, how bad it is, whether that will be amenable to podiatry treatment or not, and basically whether you're going to meet the goals that you set out at the beginning or not. But also how you're going to measure it, because as scientists you need to know whether you've been any good or not. It's really important, it's really important that you plan for success. Otherwise you can basically prepare to fail. So yeah, set out your aims, work out how you're going to meet them, decide how you're going to measure them, and prepare to say goodbye. If you don't prepare to say goodbye, your patient will still be there, not mended forever. So plan your treatments, make sure that they work together, know your treatments, understand them, do the reading again, prepare, and then measure how you did, and make sure that what you did was what you hoped you would do. If not, be honest, go back and say, well, did they improve or didn't they improve? And if they didn't improve, it's time to go back into the top of the cycle. Thank you.